What I intend to do is to start out by going over well, first of all, just sort of speak about the basic aim of all psychoanalytical treatment. What is it that we're trying to do when we conduct a psychoanalytical treatment? What is the purpose of it? What is the goal of it? What is the generic theme that applies to all analytical treatments in terms of what you're trying to achieve? Then from there, I'm going to take things one step further by drawing attention, as I so often do. And believe me, I don't bang on at this because I enjoy it. It's because I think it is so fundamentally important that it needs banging on about. And that is the fact that all our treatments can't possibly be the same, because all people aren't the same. So although there's a guiding principle that informs all analytical treatments, nevertheless, you can't do the same thing with every type of patient. And I'm going to try to set out for you, yet again, hopefully in a clearer, more lucid fashion than ever before, what the major categories of psychopathology are that we deal with, and what that means for the therapeutic task. The therapeutic task is not the same in every patient, because not every patient is alike. Not every patient's emotional difficulties are alike. But nor is every patient an island, unique and ungoverned by general principles that apply to the human mind as a whole. So it's going to be the general aim, then how that aim must differ with the different types of mental distress that we deal with. I'm going to start that different types issue by focusing on the structure of the pathology in the first instance. What is the nature of the different types of pathology? And try to make that as clear as possible. Then I'm going to go on to give some very brief clinical examples of the different types of pathology, not obviously summarizing for you 3 or 6 analyses, but rather to try to capture the essence of a few cases in order to show in real live material what I mean by the structure of the pathology and how it differs across the different categories of mental distress. Then I'm going to go on to discuss some of the basic concepts in psychoanalytical technique, the basic technical concepts, concepts like transference and reconstruction and working through and interpretation and whatnot, with the main emphasis being on how these concepts mean different things. They have different applications in different types of psychopathology. So, for example, taking the concept of transference and showing how you can't apply the same concept of transference to every type of patient. And then lastly, and I really have no idea how long that's going to take. It might take us 1.5 hours, but I doubt it. I think it's more likely going to take us the whole morning to do all of that. And then in whatever amount of time we have left at the end, I would like to invite you, in fact implore you, to present little bits of clinical material, which I'd asked you in the emails to bring at least in your minds with you, specifically focusing on cases where you're stuck or cases where there's an aspect of the treatment that seems to be particularly difficult. And perhaps most stuck of all, those cases where you feel you can't work analytically with this patient. This patient doesn't lend themselves to an analytical approach. I think that I believe that we will find, in at least a good many of those instances, that the concepts that I've summarized in the first part of the seminar will be useful for helping us to unpick some of those difficulties. Inevitably, in the time available to us, and also because this is not a clinical seminar, you're not going to be able to present a whole case. And that's part of the difficulty of our field in general, is whenever we try to convey anything about the actual material that we're dealing with, it needs hours. It's very difficult to distill a patient down to a few sentences. And I think that it's not only very difficult, I mean, it's actually impossible. You can't do it. You can't distill a human being into a few sentences. So I expect that what you're going to be raising are aspects of a case. You know, a particular session, or a particular moment in a particular session, or a particular assessment, or a particular point where you think you might have done the wrong thing, or when what you thought was the right thing seemed to have quite the opposite consequences from what you'd predicted or intended. And I think that it's a very valuable exercise to do that. I know it's not how we normally conduct ourselves in our field. Normally people stand up with a well-prepared paper summarizing everything that they said and the patient said, and not summarizing, often it's in fact transcribing suitably improved version of what happened blow by blow during the session. And it's a little bit, I mean, on the one hand, I really do know why we do that. We do that because, as I've said already, our material is so extraordinarily complex, and the human being is so complex, and the things that happen are so subtle and nuanced that you need to have a well-prepared presentation. But I think that there's also something about that way of presenting clinical material which prevents us from getting to the essence of things. You know, you can say, I said this, she said that, I said this, she said that, and try to imply, you know, wherever you think you knew what you were doing, you know, that you knew what you were doing, without having to sort of say, so this was the overall structure of the case. You know, this was the problem I was dealing with here. Or in that session, here was the thing that I think I was struggling with. And, you know, this is how I understand it theoretically. Or this is what I think the technical issue was that comes up in this case. I don't expect that you're going to be able, you know, I think, please don't be daunted by my saying this. I'm not saying now you've got to do all of this and you've got to do it brilliantly. I'm saying I think it's a worthwhile exercise for us to engage in as a group, to try to begin to, alongside our formal case presentations, to acquire the discipline of being able to distill something down to its essence, to think about some underlying structure of a sequence in a session. I actually think, I must tell you in case you don't know, because, you know, most of you are psychotherapists through and through, and not like me sort of dabbling about in a whole lot of other fields at the same time, like farming. But I am by profession first, before I became a psychoanalyst, I'm a neuropsychologist. And in the I discovered through the neuropsychological field that, in fact, just about every other clinical discipline, people do it all the time. They say, well, I have this case, you know, it's a case of this. I tried that, didn't work, so what do you think? Or, you know, I've got a case of this, it could be this or it could be that. Here's the situation, you know, please give me your opinion. And it's an ongoing sort of, you know, discussion between clinicians about their patients. With us, you know, curiously, we don't do that. And in a way, given the nature of our field, you know, which is discursive, it's got to do with, you know, trying to capture some essential thing about a person. I think that it's as much as I understand the need for it and that the fact that there is a place for it, there's something slightly pernicious about it, about our never just talking about our patients, just saying, you know, this is what's going on with this case, I think, and bumbling your way through. So you will see, I'm going to do that a little bit when I give you examples. I'm just going to say, this patient was like this patient was like that, and so on. And I hope that I will be able to then lead by example. Okay, so let's get started. I firmly believe, now remember, our topic is technique, and our subtopic is, does one size fit all? In other words, does one technique work for everyone? Is there such a thing as one analytic technique that we apply come hell or high water? A third sort of sub-theme from the culprit who originally asked me to talk on this topic was, what about cases where, it's mixed? What about cases where it's not one thing or the other? How do you deal technically with that? And I will deal with that willy-nilly as we come to it. I haven't forgotten that was part of my brief. But you'll see that the way that my take on it makes it better to organize it this way around. Start off with the pure types, and then deal with the apparent mixed cases, and then moving on to technically how do we deal with it. In case you are frustrated, and it did cross my mind that you might all sort of groan internally when I say I'm going to go over the theoretical ground of the different structures of the different pathologies, I'll tell you why I'm doing that. I really believe that technique, learning psychoanalytic technique, is completely impossible without an understanding of what you're trying to do. It's not a dentistry of the mind. This is how you do this kind of filling. This is how you do gold inlays. This is how you do root canal, and so on. You need to understand what you're trying to achieve in order for the technical rules or the technical guidelines to make any sense. And I do think, and perhaps even more so every year during the development of our field, there's a kind of an inclination toward wanting to just learn how to do it. We want how to do it manuals. And there's less and less interest in theory. There's all sorts of reasons for that. Part of the dumbing down of the world in general, I presume. Part also of psychoanalysis becoming more and more just a profession, rather than what it originally started out as, which was, forgive me for using the word, a science. The people who developed what became psychoanalysis, the discipline of psychoanalysis, weren't first and foremost practitioners. They were first and foremost interested in how the mind works. And all of our techniques flowed out of that. I think that nowadays the vast bulk of our colleagues are first and foremost practitioners, not particularly interested in how the mind works. But I deeply, strongly believe that you cannot learn how to do it if you don't understand how the mind works, because what we're doing is entirely dependent upon a particular understanding of how the mind works. And to the extent that our understanding of how the mind works is wrong, to that extent our technique's not going to make sense. And our theory has evolved over the decades, so that we now do understand something about a wider range of pathologies than we used to think was treatable by psychoanalysis. So now you can have the wrong theory in your mind about how your patient's mind works if you've misunderstood what type of patient you're dealing with. We've evolved different psychoanalytical techniques out of different theoretical understandings of different psychopathologies. You can't apply the same technique to all patients because all patients are not alike, because different things have gone wrong with them, and you need a different theory to guide what you're doing. The emphasis on the theory, I'll say it again in case I haven't made the point that I'm trying to make absolutely crystal clear. I'm going to talk in the first part of our proceedings today a lot about theory, because that's where the technique comes from. That's your guiding light in the darkness of depth psychology. It's a theoretical understanding of what you're dealing with. The technique flows naturally from that. If you look at Freud's classic papers on technique, the thing that strikes so many of us dentists of the mind today when we turn to Freud to learn how to do it is how flimsy they are. His papers on technique take up a few pages like this in one volume of the standard edition, all 24 volumes of it. And that's because it's because of everything that I've been saying to you. For Freud and for the first generations of psychoanalysts, it wasn't about how to do it. It was about understanding what's the matter, understanding what's gone wrong with patients, That gives general principles. It necessarily leads to general principles as to what you have to do. And if you've got those general principles right, the technique flows naturally from it. So my emphasis is not going to be on starting with the dentistry. It's going to be starting with the theory and showing how that informs the dentistry. It's not that I'm wanting to convert you all into scientists or into theoreticians. It's because if you're going to be good practitioners, you have to do it this way, in my opinion. That little phrase, in my opinion, reminds me that I should make as clear as daylight at the outset that what I'm going to be giving you is my opinion. I'm going to be giving you, psychoanalysis according to the doctrine of Mark Solms, evolved over his lifetime in this field. It's not what everybody believes. It's not what everybody presents as how to do it in psychoanalysis. That, of course, is inevitable. I don't make apologies for telling you what I think. So it's the only way I can do it. It would be a very different sort of seminar if my aim was to give you a sort of a overview of different people's views. It is truly what I think is the best way of going about things, but I'm very happy in the form of the interjections that I referred to earlier to hear contrary points of view and to discuss it with you. I'm not wanting to be dogmatic. I'm wanting to do the best I can to fill my brief, which is to try as best I can to tell you what I think about psychoanalytical technique and what works best and why. I will refer here and there to the theoretical schools that I've drawn on, but it is no one particular school. It's my own personal sort of amalgamation of things. Okay. Now, because I'm going to be talking theory in this first part of our seminar, I think it's very important to remind ourselves where the theory comes from. In this sense, that, psychoanalytical theory is such a dry and abstract thing. So much has been written in the name of psychoanalytic theory. And especially because, as I've said already, the early pioneers of psychoanalysis were especially interested in theory. That's what mattered most to them. It's become a bit of a kind of bore, a bit sort of tedious, a bit kind of hackneyed and stereotyped. And we hear these formulations about the Oedipus-Schmiedipus complex and the libido and the id and the ego and transference and countertransference and blah, 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 blah. So much so that these words get denuded of all meaning. They just become empty vessels, and we bandy them about, or rather we avoid those who bandy them about and just want to stick with our patients and with the lived reality of what goes on in the consulting room. You can't begin to understand the hurly-burly of what's going on in the consulting room without some guiding principles. Those guiding principles are derived from decades, in fact generations, of experience in the consulting room. So these, I beg of you, please, when I talk theory, please try to listen to what I'm saying, not just, oh yeah, I know that theory, I've heard that before, oh yes, there's that technical term, I'm very familiar with that one, and so on. I really want you to try to look past the technical terms and listen to what I'm saying about them, because it might very well not be what you think that technical term refers to. I've put a lot of effort into trying to really simplify and really distill and really get down to the essence of things. So if you will just sort of try to overcome the kind of inertia of what we've learnt about these concepts in the past, and worse still, the sort of empty phraseology that those concepts kind of evoke in our minds, and try to actually behave as if you're a beginner, and think, open your mind again to reconsidering what does that term actually refer to. Another reason why people are resistant to discussing theory and to using our technical vocabulary, our specialized terminology, is because it removes us from the experiential human encounter of working with a real human being in distress. You know, it feels, I think, increasingly, again, in the development of our field, people sort of want to talk in experiential terms. They want to talk about what the patient's fantasy was, what the patient was doing with them at that point in time, and not talk about the abstractions and generalizations of what the underlying structure of what was going on is all about. I really have great sympathy with that. It is our field, you know, the reason that it's moved so far from being a science and so far from being a medical speciality is because non-medical people, non-scientific people, humanists, social scientists, artists, people who think in a more kind of creative and literary and aesthetically informed way have done wonders for psychoanalysis. You know, I'm the first to admit that the dry theories of ego psychology and metapsychology, you know, needed to be offset by people who think more in human terms, in experiential terms, in relational terms. So I don't know if this is possible, but try, please, also keep in mind that I am very sympathetic with that way of thinking, and I'm a clinician. I love clinical work. I love people. I love being a psychoanalyst. I love doing our work. You know, I think that it's a wonderful thing to do with your life. But I say again, I really believe that unless you understand the basic principles, which can only be put in abstract terms, you're not going to be able to be as good a clinician as you could be. So it's in the service of the human task of helping another person in distress through empathy, through self-knowledge, through understanding, through a sense of common humanity. It's in the service of all of that I'm wanting to ask you to open your minds just for 6 hours to thinking about the underlying rules and principles which are necessarily abstract and theoretical. But in that spirit, let me start by saying that what is, I mean, obviously what we're doing in psychoanalytical treatment is we're treating psychopathology. We are clinicians, and we have patients. You're going to see many of the things I say are ridiculously obvious, but you know, many of the ridiculously obvious things have been ridiculously obscured. So perhaps you know by now that I like to say the obvious as if it was a new discovery, because I think that in a sense it does need to become a new rediscovery, the obvious, because we do lose sight of it. People only come to us because they see us as clinicians, as professionals with a body of expert knowledge, and they're in distress. They are not necessarily ill, but they are distressed. They are in a state of dis-ease. There's something the matter with their lives, and they turn to us for help. It doesn't mean that they always remember that that's why they've come. But that is the starting point. People who in difficulty come to us and want us to help them with that difficulty. I think that there's nothing to be ashamed of in that. There's nothing. You might wonder, why do I say there's nothing to be ashamed of in that? Because there's so many little details, little nuances, which are also valid. That one mustn't set oneself up as the expert who's going to teach the patient something. Or one mustn't set oneself up as the actor who's going to do something to the patient. And that it's et cetera, et cetera. All of these things I know. And that one mustn't have preconceptions about the nature of the relationship between yourself and your patient. You need to see where it goes. See what the patient thinks about what you're doing, et cetera. All of these things are true. All of these things are true, but they are facets of technique. They're details, they're nuances, they're subtleties, which don't in any way do away with this fundamental starting point, which is that our patients are in difficulty, and that's why they've come to us, because they believe we can help them. At least some part of them believes we can help them, and that's the part that's brought them to us. And that is the starting point, and it can't be shirked. It needs to be recognized. So what do I mean then by the patient is in a state of distress, or the patient is in a state of dis-ease, that is to say psychopathology? I'm belaboring this point because here's an example of a word that we don't even think about what it means, psychopathology. It means something very particular. It means that there's something that the patient can't cope with. Something is happening to the patient. That something comes in a great variety of forms, but there's something that's happening for the patient that they can't deal with. And it's of the essence of our psychodynamic model of the mind that what we do when there's something that we can't deal with is we push it out of mind. That is to say, out of awareness, out of consciousness. That's the basic rule. I would elevate it to being a rule, that's what people do. That's what all of us do. Not in psychopathology, in everyday life. That's what we do all the time. If there's something that we don't like, to the extent that we cannot manage it, it's not that we deny or disavow or repress or project everything that we don't like. It's that there's some things that we can't cope with. The only alternative is annihilation. There's something we cannot manage, so we push it out of mind. That's the first step. But that doesn't make psychopathology. We do that all the time. If it works, we're not ill. It comes at a price, pushing things out of mind. Always it comes at a price. But that's not the illness. The illness is when it doesn't work. So psychopathology, that is to say, the thing that our patients come to us with, boils down to this, that there's something that's gone wrong, something they can't manage, which they've tried to deal with in a way that hasn't succeeded. I have a little voice in the back of my mind all the time as I'm speaking, thinking, God, I really am sort of teaching them how to suck eggs. So forgive me. I'm really wanting to be as absolutely lucid as I can, and I think that it's worthwhile remembering this absolutely basic thing, that what ails all of our patients is an attempt to deal with something that they can't cope with by pushing it out of mind in one way or another, and therein lies a great deal of what we're going to deal with this morning. In one way or another, they push it out of mind, and the pushing out of mind doesn't work. So they're then still in distress of a kind that they can't cope with. If they could cope with it, they wouldn't come to us. Now, when I say that there are all sorts of things that we do to push things out of mind, and only those for whom it doesn't work, only those come to us for treatment, I don't mean that all of those who push things out of mind and it does work are happy and healthy. I don't mean that there's nothing the matter with them. As I say, it comes at a price. It comes at a price to them. Frequently, it comes at a price to those around them. But if it works, they're not suffering. And there's no motivation whatever for them to come to us. Why would somebody come to us for help with something they can't cope with if they have coped with it? Because the only thing we're going to do when they bring to us the thing that they couldn't cope with is open up the whole bloody wound again. And they've already dealt with it. They've dealt with it in a way that succeeds. Under that heading come many categories of psychopathology that are unanalyzable. If the patient doesn't come to you because they're suffering, you're in real trouble as a psychoanalytic clinician. Why do I say this obvious thing? Because such patients do come to us. Patients sometimes are sent to us one way or another. Very often, in the case of children, the patient is sent to us by their bosses, their parents, and the child doesn't want treatment. Also, there are cases who are sent to us by the courts. In this country, it doesn't happen a lot. In England, it happens a lot, that patients are sentenced to psychoanalytical treatment. There, a whole new set of problems arises. Sometimes patients do things because it helps them to cope with what would otherwise be unmanageable for them. And the things that they do are so harmful to those around them that they're not allowed to do it anymore. And they're forced to come to us. Not because they believe that, not because they want to see us. It's because they're not allowed to do what they want to do. Those sorts of cases raise a whole additional set of problems which are not going to be my main focus. I'll talk about them as we go along, but for the most part, those patients don't come to us. They don't seek treatment. I just don't want to give you the wrong impression in these two respects. I don't want to give you the impression that every patient is analyzable, because you'll see why I'm emphasizing that, because when I go along, I'm going to say to you as we proceed that everyone who does come to you in distress is analyzable. Everyone who comes to you and says, I want your help, you're a professional with expertise in the ways of the mind, and my mind is causing me distress of a kind that I can't manage. All of those patients are analyzable. I mean that in the sense that none of them needs any other type of treatment than psychoanalysis. In the broadest sense of the word. I'll unpack that as I go along. I don't mean that other treatments won't help them too, but I mean that I've come to learn in my own experience, and we were taught, assessment for analyzability is a very big part of what we do. And I realized as I went through the process of gradually acquiring more experience in this field, that every patient I assessed for analyzability I ended up taking on. There was no patient who I thought, this patient I can't help analytically. The ones who, for the most part, turned out to then not be able to help analytically were the ones who didn't really choose to be with me. So that's the one point that I'm wanting to, why I'm belaboring this point. The second reason why I'm belaboring it is that I don't want to give you the impression that patients whose defenses don't fail are not ill. Those patients are ill, but they don't seek treatment. So I'll say it again, just to get after all of this rambling. I'll say again the main point that I'm wanting to get across to you, which is that this word psychopathology refers to this when it refers to the patients who come to us for treatment. It refers to a person who has something that's gone wrong in their lives, something that's distressing them, something that's bothering them, that they've tried to deal with by pushing it out of their minds one way or another, as opposed to grappling with it. Grappling with it is the hard task called health. These things they couldn't grapple with, so they pushed them out of mind in one way or another. The way in which they do it determines the essence of what type of psychopathology they're going to have when it goes wrong. And I say when it goes wrong because many of these ways of dealing with things, because it's a matter of pushing things out of mind, they're very apt to go wrong. Because making as if something's not there when in fact it is there, is not the best way to deal with it. The best way to deal with it is to deal with it, to grapple with it, to face up to it. What we do as psychoanalytical practitioners is 100% determined by our understanding of what's gone wrong. It would make no sense in any other way. And to do anything differently would be a hackneyed application of technical rules that you picked up in some godforsaken university, as opposed to really being equipped to help people in distress. So what we have to do is we have to persuade the patient to give up their unsuccessful way of trying to put the thing out of mind. That's the first task of every psychoanalytical treatment. And I don't mean that we then sit there trying to persuade them. That's the technique of how you go about doing it is awfully difficult and awfully complex. And again, the result of generations of learning from bitter experience. But the underlying task, the underlying goal is first of all to persuade the patient that the way that they've tried to put things out of mind doesn't work. Why do I say persuade? I say persuade because the patient's trying to put the thing out of mind because they cannot cope with it. So it's not something that they're willing to do very readily. From there flows many, many basic psychoanalytical concepts, which we're going to come to about technique. Not least of them, resistance, which comes in great many forms and underlies a great many other technical concepts, like transference, as you'll see. But for now, just to keep the simple map as clear as possible, you have to persuade the patient that the way that they've tried to deal with their difficulties hasn't worked. Therefore, you have to persuade them to look at those difficulties again. So the first step is persuade them that what they've done hasn't worked, in order to, secondly, allow them to re-experience, to see again, to face again what they can't cope with. That's an enormous task. It's the crux of the problem. The patient can't bear it. That's why they've done this desperate thing, which is rather than deal with it, they've pushed it out of mind. Having brought the unmanageable psychical reality, whatever it may be, back to the patient's awareness, our task then is to help them to find another way of dealing with it. And the ideal is to help them to find a way to actually grapple with it in the world, rather than push it out of mind again. Happily, this is the homeward stretch in a treatment, because the worst is over once the patient has recognized what the thing was that they couldn't cope with. Once they're facing up to what they couldn't cope with, invariably, with the help of you, a professional, they can find a better way than what they used before. Because the way that they used before was a desperate crisis, one way or another, usually initiated early on in life, when we're at our weakest. Patient has many more resources usually by the time they reach adulthood than they had then. So what seemed like the only way out when they were little is not the only way out at all. Once they can bring to bear their greater experience, their greater understanding of the ways of the world, with your help. When the thing comes back to their awareness, when you persuade them to face what overwhelmed them in the past, they find it's not as overwhelming as they imagined it was. The desperate getting rid of the thing wasn't, in fact, necessary. It wasn't as catastrophic a situation as they initially believed it was. The other reason why you're on the homeward stretch is because anything is better than pushing things out of mind. Any amount of actually facing up to the thing is better than pushing it out of mind. It can only lead to a better outcome. Let's not forget that's why it failed in the first place. Okay. So just to recap, and I see that I'm probably going to take all 6.5 hours talking all by myself because I've got through the first paragraph of my summary here. The patients who come to us for treatment have something that they can't cope with, which they've pushed out of mind, and that something won't stay out of mind. That's their illness. That's their symptom. The thing won't go away. It keeps on coming back. They're therefore in trouble. There's something they can't cope with, and they try to get rid of it, but it won't be gotten rid of. So they're in trouble. So they come to you. Your job is to persuade them to face up to the thing, to look at it, to see it, to recognize it for what it is, the thing that they couldn't cope with. It's very difficult because they can't cope with it. Major part of psychoanalytical technique is helping the patient to cope with it. Persuasion is possibly not the best word, but it conveys the essence of it. And then, having done that and seen what it is, to help the patient to find a better way of coping with it, ideally by actually dealing with it in reality and not pushing it out of mind again. Now, I've said more than once in this introductory sort of formulation, sorry, may I say before I go on, because it's sort of so important to me, please notice what I'm trying to do with this seminar. I'm trying to distill things down to the absolute simplest. Please do me the favor of trying to hold on to it, because I really believe these simple formulations are lifesavers when it comes to, here comes a patient, all snot and trana, hurling abuse at me. I don't know what the fuck to do, and then I think, I know what's going on. This patient has something that they can't cope with, which they're trying to push out of mind, and it's coming back at them. And my job is to help them to see what the thing is that they're trying to push out of mind. And then, once they see it, to help them to find a better way of dealing with it than to push it out of their minds. Full stop. Finish and klar. That's your job. It's very simple. And to have that simple map in your mind, at least let me rather say, I have come to find that when I saw my first patients, I didn't know what was going on. It was chaos. It was confusion. It was bloody difficult. I was lost. I went to my supervisor, begged them to tell me what to do. Then I read in books what to do. And then I learned, you do a filling like this. And then I tried to do the fillings and it didn't work. And then after effort and effort and effort and effort, eventually I managed to work out for myself some basic understanding of what's going on. And in my case, it has been very, very helpful to me. So that's why when I'm asked to talk to you about psychoanalytic technique, I'm imparting to you my opinions as to what, in my experience, has helped. And I find it very, very helpful in the trenches with bombs going off to remember what the war is about. Okay. Now, I'm leading up to this essential point that, as I've forewarned you, is my main banging on about thing in this psychoanalytic, South African psychoanalytic initiative. My contribution to it, apart from the bureaucratic one of trying to get our structures in order, the educational one, this is my main shtick, and you all know that very well by now. When I say pushing the thing out of mind is the thing that all patients do, and that something that doesn't work, and that's the structure of every psychopathology, the broad categories, the three different types of psychopathology, and there are three broadly types of psychopathology, have to do with three different ways of pushing things out of mind. I don't know if it sounds unlikely that there are only three ways. It doesn't really matter whether it sounds likely or unlikely. In our experience over generations of working with these patients, we've learned, broadly speaking, there are three ways. If there were 7, I hope we would have learned that. If there was only 1, which one sometimes seems to, you seem to get the impression in listening to scientific meetings, so-called scientific meetings in psychoanalytic institutes, that there is only 1. If there was only 1, I would be as happy as everyone else. But there isn't only 1. Nor are there 100, thankfully. There seem to be 3. 3 broad ways of pushing things out of mind. These 3 ways coincide with the 3 broad categories of psychopathology that we call neurosis, narcissistic disorder, and psychosis. The terms that Freud used, as you all know by now, was transference neurosis, narcissistic neurosis, and psychosis. But for short, we can speak of neurosis, narcissism, and psychosis. When a patient comes to me for so-called assessment for analyzability, I find that this is what I now do. My question is, am I dealing here with a neurotic, a narcissist, or a psychotic? That's my question. It's not, can I analyze this case? If the patient's coming to me with mental distress that they believe I can help them with, I believe I can try, and I can try by using the armamentarium of techniques that psychoanalysis has available. Depending on what type of patient I'm dealing with, we have a technique for it. That doesn't mean that we have an equal chance of succeeding in every case. The less severe the case, the greater the chance of succeeding. The more severe the case, the less the chance of succeeding, but that doesn't mean you can't help. And I'm not a therapeutic zealot. To tell you the truth, I really don't believe I am. I'm not one of those people who needs to cure, who needs to help, who needs to feel important, for that matter, by making a patient grateful and beholden to me. I'm really not. It's probably I'm more of the same ilk as the first generation of analysts. My point of entry into psychoanalysis was an interest in how the mind works. Starting in neuropsychology, recognizing that they had a pitiful understanding of how the mind works, I scrabbled around to try and find a better one, and turned to psychoanalysis to help me as a neuropsychologist. My motives were largely scientific and theoretical, not therapeutic. It came as a surprise to me that I found out I actually could be a decent therapist and that I enjoyed it. So I'm only saying this on the basis of experience, empirical experience. I've learned if a patient comes to you, as long as you understand basically what's the matter, there is something that you can do as a psychoanalyst or psychotherapeutic, psychoanalytic clinician that can help. But if the patient comes with lung cancer and you treat them as if they have an upper respiratory infection, you're not going to help. So the first task is to understand what's the nature of the pathology. Obviously, you have a greater chance of helping a patient with an upper respiratory infection than you have of helping a patient with a lung cancer. And you get degrees of lung cancer too. But that doesn't mean that we don't have a treatment that's appropriate to lung cancer, and that's the one you should be applying. As the clinician, the professional, the expert that the patient, the sufferer has come to for help. So you need to understand what the structure of what the type of disorder is that you're dealing with, so that you know what therapeutic procedure to apply. And you notice the language I'm using. It's the language of medicine, the language of therapeutic procedures and all of that. And I've already given you all of my caveats and provisos and qualifications at the beginning, so I'm not going to keep on repeating myself. I don't see us as surgeons operating on the mind. I see us as human beings trying to help fellow human beings in distress. But in order to get to the underlying principles, the abstract generalizations, I use this kind of analogy to medicine, to physical medicine. Let me make here quickly an aside, which will come up again and again as we proceed. Of course, you do get patients who have lung cancer and a cold at the same time. That doesn't mean you mustn't treat their cold, but that's not your main job. So first and foremost, what you've got on your plate here is a patient with lung cancer. That's your diagnosis. They also have a cold. They might also have a sore ear. Sore ears are very distressing. So you treat the sore ear. But that's not the main thing that you're doing. And that's the sort of guiding principle that I use when I assess a patient. Everybody has got elements of a neurosis, elements of a narcissistic disorder, and elements of a psychosis. or at least let me say they use neurotic mechanisms, and they use narcissistic mechanisms, and they use psychotic mechanisms. Everybody, to a greater or lesser extent. But what you've got to treat is what's the matter with them, what the core organizing structure of their disorder is. And that's what I'm now wanting to teach you. These three things can't coexist. You'll see why as I talk about it now. They can't coexist as the main structure of the patient's mind. They're incompatible with each other as the main structure of the patient's mind. Again, maybe I'm saying the obvious, but I'm afraid I've been in sufficient situations to realize that not everybody thinks this way, that I'm going to underscore the obvious. Psychosis is a very serious illness. It's not something that is the main thing that's the matter with 95%, 99% of the patients who come through your door. You hear time and again about our patients' psychotic mechanisms, and it drives me bloody bonkers. It really does. And forgive the strength of the effort. I'll tell you where it comes from. I deal with psychotic patients a lot. I know what psychosis is. It's probably I see more psychotic patients than any psychoanalyst alive today, because I work in a neurology ward, where the psychiatrists send me their most psychotic patients who they're so psychotic they think maybe they belong in the neurology ward. Maybe there's something wrong with their brains. And then there are many cases of neurological disease who go psychotic. So I see lots of psychosis. I know exactly what psychosis is. It's no fun, it's no picnic. And none of us around this table are psychotic. And I would be amazed if in your practices, if you're in ordinary private practice, if you have more than one a year that comes to you. And I think that's probably a gross overestimation. Narcissism, on the other hand, is rife. It's everywhere. It's also a very severe disorder. I won't indulge in speculation as to why it's so rife in our society today. It seems to have become more prevalent than it used to be. But that doesn't matter for our present purposes. I'll just say what I know you all know, which is that narcissistic disorders come through your door far more often than you would like. Having said that, neurotic disorders are more prevalent than people seem to realize, still today. I think that's, and I know I've said this before, but I will say it again, that's because the discovery of how narcissistic mechanisms work and how we can treat them analytically is more recent than our discovery of how neurotic mechanisms work and how we can treat them analytically. So the light shines more brightly in our education and in our reading of contemporary theorists on narcissistic mechanisms. And I believe that we frequently mistake neurotic difficulties for narcissistic ones. I think that we want to practice the latest technique. That doesn't mean that it's the right technique for every patient. I think that psychotic mechanisms are grossly overdiagnosed among psychoanalytic practitioners. They really need to think twice, if not 15 times, before they use the word psychotic mechanisms. They don't seem to know what it means. They've forgotten what it means, and that's a tragedy. Neurotic disorders are underdiagnosed. We mistake neurotics for narcissists too much. But that's not to deny that narcissism is rife in contemporary society, in our cities. If you go read Freud or the other first-generation analysts, they will tell you psychoanalysis is a technique that we apply only to the transference neuroses. In The Morning in Melancholia, Freud tells us we cannot treat depression analytically. It doesn't work. Freud says narcissistic pathology, you need to assess for it in order to exclude those patients because we can't treat them. Then the next generation of analysts, Melanie Klein foremost among them, cracked the code of narcissistic disorders and evolved techniques that work for those disorders, which we didn't have in Freud's day. And in the case of psychosis, there's with Melanie Klein and her followers, there was a much deeper understanding of what's going on in psychotic illness. But I think that the major advances that have occurred in our understanding of psychotic illness have been outside of psychoanalysis. And as you all know, I have one foot outside of psychoanalysis. And one of my main causes for getting grey and bald is that I'm constantly trying to persuade my analytic colleagues, that we've made progress in understanding psychosis outside of psychoanalysis, and we need to bring that understanding into psychoanalysis in order for us to continue to develop our understanding of the inner world of these patients and what's really going on there. So I think that history shows that there is progress in psychoanalysis. We don't have a fixed, immutable understanding of how the mind works. And when I say I'm going to tell you what we know about how the mind works according to Mark Solms, it is according to Mark Solms in 2008 that it's the best understanding that I've been able to put together at this point in time, and my views change, let alone our discipline. So I take this as an opportunity to try to persuade you of my views, which are very much 21st century views, based, though, on everything that came before, incorporating everything that came before. And I don't just mean it's an accumulation of understanding. I believe, as you'll see after the coffee break, that there are things about Freud's model of the mind which are misleading, which obscure things, and that the Kleinian development helped us to understand things better than Freud about how the mind works, which has implications also for so-called transference neuroses. And I'm going to sketch those for you on this little pad up here. So, I really do believe there's an accumulation of knowledge. I think, though, since I'm on a roll, I'll tell you something else. I think that there is, for some reason, and I really don't know why, and I have some little hunches, but I don't feel particularly persuaded by them. I think that there's a tendency toward narcissism in psychoanalysis as a discipline. I think that we suffer from a kind of, we're in a relationship with our ideas, with our theories, rather than with the outside world, with the object. And there's therefore a great reluctance to take on what's being learnt outside of our discipline. I think the analogy to narcissism is sadly very apt. We're in a relationship with ourselves, rather than in a relationship with that lovely breath of fresh air called the outside world. The mind is not the possession of psychoanalysis. The mind is something that's studied by a great many disciplines, each of which has their own strengths and weaknesses when it comes to what they're able to elucidate. And psychoanalysts are very reluctant to take that on board. And the same applies to schools within psychoanalysis. There's an incredible tendency to splitting and everything that goes with it in relation to our schools, so that we have people who attach themselves only to what Freud taught them, and they don't want to know about anything that came after that. It's like it's a form of fundamentalism, which we see around us today. It's in such frightening forms, which is a narcissistic disorder. If you have a look at the roots or the mechanisms contributing to, for example, Islamic fundamentalism, it's narcissistic injury. And I think that we really need to look very carefully at ourselves. We're doing the same thing, the fundamentalists, who don't want anything to change, or who think, that since I've had a new idea and it's mine, everything that came before me is shit.